Good evening, everyone. We're just waiting for a couple more people to trickle in from the waiting room, and then we'll get started shortly. Thank you for being here. All right, it is 5:05, so we can go ahead and get started. Good evening, everyone, and thank you for joining us tonight for the FuturePedsRes DO webinar and mentoring session for the upcoming 2025 match cycle. If you attended our kickoff webinar on Monday, we welcome you back. If you're joining us for the first time, we're so glad you're here. We have a lot of great information and speakers who will be speaking tonight. And so let's go ahead and dive right in. My name is Stephanie and my pronouns are she, her. I'm a rising fourth-year student at Western University of Health Sciences, College of Osteopathic Medicine of the Pacific Northwest. And I serve as one of the co-directors for FuturePedsRes this year.
And my name is Caroline Maltese. My pronouns are she, her. I am a fourth-year student at Penn State College of Medicine, and I'm the other co-director for FuturePedsRes.
And before we start, we would like to acknowledge our Association of Pediatric Program Directors Faculty Advisor, Dr. Michael Dell, who is also the Vice Chair of Education at Case Western Reserve University School of Medicine, and Colleen Hughes, who serves as the Associate Program Director for APPD, as well as acknowledge our ComSep Faculty Advisor, Dr. Rachel Thompson, who is an assistant professor of pediatrics and director of pediatric undergraduate medical education at the Boston University Chobanian School of Medicine.
Hi everyone, my name is Sheena Bedi. My pronouns are she, her. I am a medical graduate from India and I'm serving as the Associate Director of Webinars for FPR this season. And now I would like to hand it off to our Assistant Director of Equity, Faria. She will be the moderator for tonight's panel.
Hi, everyone. Thanks for the wonderful introduction, Sheena. My name is Faria, pronounced she, her, and I'm a rising fourth year at the Texas College of Osteopathic Medicine. Super excited to get started with tonight and get into our wonderful sessions this evening. We'll be starting off with a brief overview of today's evening before we officially meet our wonderful panelists for the evening. We'll be chatting a little bit about our webinar series with FuturePedsRes before introducing our much anticipated panelist Q&A and then opening the floor to a live Q&A session for any remaining questions you may have. Following our closing remarks, we'll be joined by resident osteopathic pediatricians where we will have an unofficial social event with resident happy hour. So a little bit about FuturePedsRes. We are an initiative that started earlier during the pandemic intending to provide pediatric applicants with information throughout the residency application and interview process for pediatrics. We're really excited to start up with our webinar series for this year. We have a few more mentoring sessions coming up, with the next one being on July 1st, before we officially start up with our program sessions throughout the rest of July and August. Our sessions are intended to provide knowledge with the application interview season and allow applicants the chance to connect with programs and learn more about each program's unique residency training as well. We also have live time for a live Q&A each session, and today's session will specifically focus on advice for osteopathic medical students applying PEDS this year. And now the moment you've all been waiting for, on behalf of FuturePedsRes, I'd like to offer a warm welcome to our esteemed panelists for tonight. I don't know if she's here, but our first panelist for tonight is going to be Dr. Laura Bodie. Dr. Laura Bodie, pronounced she, her, is a pediatric residency program director at OMICO at Oklahoma State University in Tulsa, Oklahoma. She's also a pediatric hospice at the Children's Hospice at St. Francis. And next, I'd like to welcome Dr. Jennifer Duke, pronouns she, her. Dr. Duke is assistant professor and associate program director at UT Dell Medical School in Austin, Texas. She's also a general pediatrician at the Community Care Health Center in Austin, Texas. Thank you for joining us, Dr. Duke and Dr. Budee. We'd like to welcome next Dr. Chris Rooney, pronouns she, her. Dr. Rooney is the Vice Chair of Education and Program Director at the Lehigh Valley Health Network. She's also a pediatric hospice and diagnostician at the Lehigh Valley Riley Children's Hospital. And next, we'd like to welcome Dr. Tyree Winters, pronouns he, his. Dr. Winters is an assistant professor and program director at Gorham Children's Atlantic Health. He's also currently serving on the ACOP Board of Trustees as vice president. Thank you for joining us this evening. So as we officially welcomed our wonderful panelists, we're going to start off with our panelist Q&A session. These are questions that were compiled from frequently asked questions and questions that our attendees tonight have submitted. Our first question is for Dr. Budee or anyone who is able to take the question. What factors should an osteopathic applicant consider when deciding how many and which programs to apply to? I'm not sure if Dr. Budee is here, so Dr. Winters, would you be able to take this question, please?
Sure, of course. Can everyone hear me okay? Sweet, awesome. So in terms of the number of applications that osteopathic medical students should consider when applying to different programs, I think the thing is when you look at the national average for the number of programs that typically a candidate, regardless of if they are a USMD, a USDO candidate would normally apply for, it can vary, but it typically ranges around somewhere around like that 30, usually 30 applications or 30 programs. Typically what I would tell people is that it's really based off of you as a candidate and what you're considering and looking for, right? So the one goal is that you don't want to kind of spread your reach so far. If you know that there are certain things that are going to be important for you, whether that is location, the size of the program, certain things that are different, that are offered in that program. And the reason why is just because as you are considering the applications, once you start to get interviews that come into play, it's quite difficult to be able to interview at a large number of places and still be able to handle all of the rigors still of your fourth year medical school. So you definitely want to be judicious. Plus, that's just looking at the operational practical side of it. We also have to think about the financial side. It is not cheap to apply to a lot of different programs. And so I always say, like, be intentional about where you're thinking about where you want to apply for. And that should be able to help guide you in terms of thinking about you as an applicant, what are things that are important to you, and being able to talk with your advisor to see would it be recommended to apply to more based off of your application.
Thank you so much, Dr. Winters. Dr. Duke, is there anything you may like to add on, or we can move on to the next question? Okay.
Yeah, I think
no,
it's totally fine. Sorry, I unmuted and then stopped my video all at the same time. But I think that Dr. Winters really gave a perfect answer, and I would sort of echo everything that he said. 30 sounds like a good number. Know thyself when you're entering the process and what you want and really what you're looking for out of a program, and then be specific about the programs that you are applying to that meet those needs for you.
Thank you so much. Okay, we're going to move on to the next question, and Dr. Duke is going to take this one, please. With the transition to pass-fail, how necessary is it for an osteopathic applicant to take both USMLE Step 1 and COMLEX Level 1? And a follow-up question to that is, how necessary is USMLE Step 2 in addition to COMLEX Level 2?
Yes, thank you for the question. And thank you for having me here. It's so I scrolled through and I saw how many people were here, and I was like, wow, look at all these future pediatricians. It's really exciting to see all of the ones coming after us in the field. So it's really great to be here with you all. For this question, I mean, I can speak for our program, and I can speak for kind of what the general sense of what I heard at the program directors meeting, and that is that we are a DO friendly specialty, and that if you're applying to our program at University of Texas Dell Medical School, and I'm looking at your COMLEX score, or I'm looking at your USMLE score, I have the same thoughts about it. And there is no real difference or expectation that you take the USMLE if you have passed both COMLEXs, and that's the test that you take. So that's what I can say about our program. There is not a value judgment difference between the COMLEX and the USMLE. I do understand that there are programs out there that require both, that require med students take both, or at least historically there was. And I would just think about, looking at the numbers of DOS residents who have been at that program, and maybe what it says about a program if they don't honor the COMLEX or require the USMLE, just in terms of how friendly they are to DO students in general. But yeah, at our program, you don't have to take the USMLE.
Thank you so much, Dr. Duke. Dr. Winters, would you be able to share a little bit about your program and your thoughts on this as well?
Yeah, of course. Coming from it from multiple lenses here. So in addition to being vice president, president-elect at ACOP, but also being on the board for the Association of Pediatric Program Directors as well, there is, to Dr. Duke's point, it's absolutely correct. Not only do you think about it from the lens of not only the APPD, but also the consortium of groups of pediatric graduate medical education focused groups, such as the APPD, COMSAP, MSPDEC, FuturePedsRes, who have come together to have said that we want to make sure that there's parity in the licensure exams. So meaning that there is well-documented evidence that shows if you want to compare the COMLEX score and the USMLE score, this is the formula, this is the availability to be able to do that. And so with that being said, I think it is already at a point where we are viewing not only the USMLE step 1 and COMLEX level 1, but also our step and level 2s to be pass or fail. That's been a general consensus of most places. Are there places that still have these biases against osteopathic physicians? I would be remiss if I told you no, that there is not. There are still biases. However, you have individuals, both MD and DO alike, who are fighting the good fight to make sure that parity still remains, that we are spreading the message that there should be no consideration of we are just as good as, we are equal. Point blank and to the point and simple. And I'm a firm believer that if you don't want my license, you don't want my degree. And that's just always been my principle that I stand by. And so you have to make the decision of where you want to be at. But I've always said that I come as a whole package. You cannot separate my DO and my name. So with that being said, think about it from that lens. And if that gives you any type of idea of how my program runs, you know that we wholeheartedly accept COMLEX and USMLE.
Thank you so much for the wonderful perspective, Dr. Winters and Dr. Duke. We're going to go ahead and move on to the next question, please. So we're going to hold the floor with you, Dr. Winters, if that's okay. This question is, what is the best approach to addressing a low COMLEX USMLE score or other academic red flag on ERAS and during interviews?
Yeah, that's a great question. I think the most important thing is making sure that when you're thinking about how, what was the rationale or what was the purpose of having these quote unquote red flags. One thing that I think it's that everyone should remember as an applicant, and I can tell you, sitting in both seats as a program director and as an applicant, I can tell you that, of course, all of us have this feelings of like, oh my God, this was not necessarily the best, or that was not the best. But also we take into account that you're, one, a human being, two, that there are going to be things that will be present in your application that may not be the most quote unquote desirable. but it's also a reflection of who you are as an individual, as a person. And so if you can tell me the rationale behind it, what did you learn from that? How were you able to take that situation and be able to apply strategies to be able to make sure that you will be successful when you go into the program? Dr. Duke can tell you, Dr. Dale can tell you, all the people on this call that are active in graduate medical education, the one thing that we want above all is to make sure that you walk out of our programs being a competent pediatrician. That's our main focus and goal. And so what we just want to make sure is that the strategies and the things that you have put in place that got you to the point where you're able to apply into our residency programs, you've learned from them and you've able to apply them once you go on to graduate medical education. So just having a way of being able to answer that and be able to not necessarily twist it, but just being honest and being able to say like, hey, this is what happened, but this is how I was able to move forward. I think that's the best way to address them.
Thank you so much, Dr. Winters. Dr. Duke, is there anything you might like to add on before we move on to your question?
Yeah, I would just say that I've had some students that, they had a lower score, but they passed it. And then they really wanted to dwell on that when I wasn't the one bringing it up. And I kind of feel like if you pass that test, then you passed it. There's a spectrum of people's strengths and weaknesses, and just some people are not great test takers. And if you put in the work and you knew who you are and you studied to the point where you needed to pass that test, and then I see on your clinical rotations, stellar, excellent team player, all of those things that really are going to make you a great pediatrician, I'm happy. And I don't think that it necessarily needs to be something that you're apologizing for once you clear that hurdle.
Thank you, Dr. Duke and Dr. Winters, for the thoughtful perspective on this. We're going to move on to the next question. How can osteopathic applicants best strategize the 10 experiences section on ERAS? And follow-up question is, how can applicants approach discussions surrounding experiences with OMM or OPP during interviews? And Dr. Duke, you can start us off, and then Dr. Winters, I know his picture's on here, but we'll let both of you take lead with this.
So I would love to take the second part of the question. It's okay.
That sounds perfect.
I will just say that there is, sometimes when you're going through your training, medical school or residency, at the moment, you don't really know the lesson until years and years later. And recently, it's just become a little bit more clear, because we have so many DO residents in our program, is that I do see subtle differences in the musculoskeletal exam and the comfort with laying hands on a patient coming right out of medical school. And I think that, talking about just the amount of time that we spend in medical school in that OMM lab and laying hands on each other, even if, you're not going to be doing, what is it, high velocity, low intent. I can't remember it. I don't do manipulation, but I will say that even though I'm not doing that in my practice, just feeling the subtle differences, noticing like, oh, okay, that his leg has a little bump on it and mine doesn't, and that's okay. And just the variations of normal in the human body and the amount of time that we spend just like working on each other is a huge benefit when you come out into residency, and the comfort of just laying your hands on a patient. So I would say that if you do plan to do manipulation, you could say that, you have this foundational experience and whatever that meant to you when you were in OMM lab. And if you're going to a program that doesn't do manipulation, you can say that, you gained this benefit, which you all have who are coming out of osteopathic medical school.
Thank you so much, Dr. Duke. Dr. Winters?
Yeah, of course. Two things. One, Dr. Duke, I was cracking up because I was like, yes, high velocity, low amplitude, HVLA. For the 10 experiences, my common thing will always say be mission driven. And being mission driven means that when you're thinking about these 10 experiences, just because something is listed on ERAS, quantity does not equal quality. So you don't always have to fill out all 10 experiences, especially if they are not of quality. What I mean by that is it doesn't mean just because something is not necessarily so on the nose obvious about why this is important for you to be a good pediatrician doesn't mean that you shouldn't put it down, especially if it's something very important or it reflects who you are as a candidate. So, for instance, somebody had talked about being a licensed nail technician on their 10 experiences. And so you're like, how does that relate to pediatrics? But they were able to so eloquently state why being a small business owner, being able to utilize that skill, not only to be able to develop dexterity, but also to be able to become comfortable with understanding nuances. They talked about their understanding of seeing different hues in individual skin and how that was able to help them with their diagnostic abilities. And it was just so like, oh my gosh, you really took something that meant so much to you that somebody would have been like, I don't have the slightest idea about nail technology, but you were able to show me how you related that. So with that being said, use those experiences in that section to be intentional, to be mission driven, to tell me more about who you are as a person. You'll be surprised at some of the things that we look at that will pique our curiosity, may make us say like, well, I want to interview this person, or be something that will be a great conversation starter when you're doing an interview. And I can tell you, when you're halfway through the interview season and you are on like your umpteenth interview, you sometimes it gets redundant. So you want those kind of those conversation generators. In terms of the approach to OMM OPP during interviews, I think it's very important, especially if it's important to you. I am somebody who I purposely chose my residency program because I wanted to make sure that I was able to do OMM and continue to develop that skill. We actually, in my program, have an OMM curriculum. So not only do we, and it's for not only our osteopathic, but also our allopathic residents as well. So my allopathic residents are the ones who probably use way more on them than my osteopathic residents some days. Believe it or not, they really get into it. But with that being said, I think it's again being mission driven, talking about what that means to you, how thinking about OPP is so much more than just being able to manipulate. Just because Dr. Duke may not do manipulation as much, it doesn't make her any less of a deal than it makes me. And I can tell you the same principles and philosophy that she learned, she applied daily in her practice the same way that I do. So I think that's so important to be able to make sure that you highlight that. It's not should be lost on you to know that osteopathic physicians, especially in places like pediatrics, we are sought after. And I'm not just blowing smoke up your tail. I really do mean this. We really are sought after. People do look for us. So be proud of your osteopathicness.
Thank you so much, Dr. Winters, Dr. Duke. We're going to move on to the next question, please. What steps can an osteopathic applicant take to connect with a residency program during an audition rotation? Yeah, we can start off. Thank you.
Yeah, I think that different programs do this differently. And the number one recommendation that I would have because I know that not all audition rotations are going to be that on the ward sub-I, but you might be doing an ID elective, or you might be with the rheumatology service. And in those cases, I think it's so important that you connect with the residents and you really feel out what the residents' life looks like, how they feel about the program, and get a sense from the house staff what what the program is really like. And ways of doing that are really just kind of when you start asking the clerkship director or the person who manages medical students to put you in touch with the chief residents. And then the chief residents will be able to take it from there in terms of connecting you socially to the, actually, what you should know is that chief residents are the conduit to everything. And the chief resident will connect you with residents. They'll connect you with faculty that might be of interest in your area of specific interest in pediatrics. They'll be able to really show you what you need to know or what you're interested in that's specific to their program. And then also just to kind of give you an overview. And then some residencies for when you're on your sub-I will do your interview at that time, and they interview all of their sub-Is, and then other programs don't do that. But don't feel offended if they haven't asked you to do your interview. Some programs just have it set up that it's kind of, they put all of the applicants in the traditional interview pool.
And I think it's also to be said too that you want to Dr. Duke hit the nail on the head, like chief residents and residents in general are someone that you definitely want to connect with, be able to learn the culture. Remember, this is such a bi-directional situation, right? So not only are you hoping that they kind of see you and see your abilities, but also that you can see more about the program, the culture of the program. But the other thing I was going to say is just because don't always search for someone based off of their title. You'll be so shocked and surprised who can help you to have a better understanding of the program, but also who will be a huge advocate for you, a huge sponsor for you that you don't even recognize or know. So case in point, like to Dr. Duke's point, if you get an ID rotation or a rotation that may not be like one of the more inpatient heavy, or you see a lot of the residents and have a lot of face time among the program director, that faculty member or those individuals that you may come in contact with during that audition rotation or that rotation in general can still be huge advocates for you and speak to the program directors. I can't tell you how many my faculty would come to me and say like, oh God, this kid, blah, 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 or this person, blah, 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 is such a great candidate, and will write flowing and just glowing letters for you or emails or something along those lines. And that really has made a decision for me with certain candidates where I will place them on my rank list.
When we're in our intern selection committee, there's this like one line that is, there's nothing like a known entity. And so when we know you and you're good, we're going to put you high on that list, kind of regardless of what else is going on that application.
Thank you, Dr. Winters, Dr. Duke. We appreciate this. We're going to move to the last question. What makes a strong candidate for pediatric residency at your program? And then caveat to that is, what is one piece of advice you have for osteopathic students heading into the upcoming application and interview season? We're technically two separate questions, but you guys can tackle it. Have the floor.
Do you want me to go? Oh, okay. Sweet. So what makes a strong candidate in my pediatric residency program? I definitely would say biggest thing that we're looking for is someone who it can show that they align with the mission of our residency program. And so if you look at anyone's residency program, we look at their mission, I think we focus in on that because a lot of times you hear this term like, are they a good fit for my program? And historically, a good fit for a program means that they're someone who is very reminiscent of people who are in my program before. And it's usually have been a negative connotation well, not negative connotations, but usually has been negative for individuals from marginalized backgrounds, right? So a fit may not look like, I may not look like the average person that has traditionally been in that program. So we try to be very mission focused. And so I look at those things. Are you being able to show me that you have intellectual curiosity? Are you able to show me that you are that you strive to make sure that you are providing health equity and being able to bring diversity, equity, and inclusion within our program? All of those things are super important for us. And so that's what we look for in our candidates. And so we very much, just like again, that consortium of organizations, we talk a lot about holistic review. That AAMC talk about holistic review. We really do ascribe to that. But for the one piece of advice I would give you for osteopathic students heading into this season is one, I really, really hope and pray, and I hope that I conveyed this, that the imposter syndrome that we sometimes can have just as individuals who are in medicine, let alone when people add in thinking about like, oh, well, I come from an osteopathic medical school and I know that some people are, may have viewpoints different because of this or may have some type of whatever biases against it. I really want you to understand, don't let that internal saboteur get their hands on the progress and work that you've done. You are so worthy to be in the seats that you are in. You are so worthy to go into any of the 212 programs that we have in pediatrics. Do not let anyone, most importantly yourself, ever tell you that you are not worthy for those things. That's the one piece of advice I wanted to give you, because everything else will fall into place if you always keep that one principle in your mind. And then I'll turn it over to Dr. Duke.
Yeah, so I'll say a couple of things about this. One is I actually really like reading personal statements, and it's always like a little connection that I make, like, okay, well, who's this person going to be after I read their personal statement? And that's a little game that I play with myself to get through 200 interviews. But I will say, don't be afraid to just look back at those osteopathic principles that you learned your first day of medical school when you're writing that personal statement. When did you see a time when you saw a physician where they applied form and function? When did you see a time when you saw a physician apply holistic approach to a patient? And you just kind of think about those osteopathic principles, and you can write a personal statement that's going to be meaningful to you, and probably one of the reasons why you chose to become a DO. And it's probably going to be meaningful to the reader as showing you as somebody who is a good fit for this field. And then the other thing that I'll say is, makes a candidate a strong candidate is the clinical experiences that they've had and how they can connect in their interview those things that they learned, good and bad, and particularly when they talk about mistakes that they've made or that they've seen made, and where to grow, and kind of the layers of kind of the evaluation of those opportunities that come from any mistake that's made in medicine. So I think that those are a couple of things that I would be really prepared for when you're going into the interview season.
May I say one more thing? Thank you, Dr. Duke, because you have brought up something I totally forgot, that this is one piece of advice that I have been giving out more so lately, especially among, and since we're all among our osteopathic family, one thing that I will tell you is that when you're looking at applications, especially when you're looking at the medical student performance evaluation or the MSPE, you can look at that prior to your ERAS application going out. I strongly encourage you to get a chance to look at those things. Get a chance to go back and look at your evaluations that was done by your preceptors. And even for those individuals who may not necessarily be entering into their fourth year, already in their fourth year right now, if you're in your third year, super important. Unfortunately, sometimes what you will find is, especially among our preceptors, we don't tend to write, meaning from our osteopathic medical schools, tend to write as much of a narrative, especially when it comes to the summative type of a narrative or a background when it comes to your clerkships. And so because of that, what happens is that you may miss the opportunities to be able to highlight a lot of the work that you were doing in terms of your clinical work, your clinical acumen. And so you really want to make sure that that's present. So when you go and check your MSPEs, check and make sure, is there anything that's a discrepancy? Do you have comments that are listed or things that are shown up as being incomplete or any of those things at all, to be able to help to correct those, because that's a huge portion of the things that we look at when we're doing that holistic review. But then if you also notice that it tends to maybe a little bit lacking, that piece of advice that I always give is you can actually go back and talk to some of your preceptors and just say like, hey, I was just noticing this, like I remember when we did this particular case and we did this work. Is there any way that you can talk about that in my comments or something along those lines? Obviously, you're not trying to tell someone how to grade you or be kind of, very. I've had some people that are become like, "Whoa, calm down there." But at the same time, you also want to make sure that you are highlighting the work that you have done as well. So that's hugely important.
Thank you, Dr. Winters and Dr. Du, for the thoughtful perspectives. We're going to go on to the next slide, and we're officially opening the floor to any questions for the live Q&A portion of our webinar. If you have any questions, please type in the chat, and we will address them to our wonderful panelists. Our first question is from Madeline. Do you have any suggestions or advice for couples matching as a DO?
We consider couples matching in our program, and I think that it's not all that different than couples matching for allopathic residents. There are kind of we talk with each other, if the IM resident is matching with the PD resident, and then they really liked that person and we really want the PD, then we'll say like, oh, they're in the third quartile, could you think about maybe moving them to the second quartile so we can maybe get these two? So I would say that couples matching is not a choice that you should go into lightly, but I don't think that it disadvantages you as a DO. I think that maybe the consideration of if your partner or other half of the couple is matching into a highly competitive field or a spot that only like has one spot a year, something like that, then my advice would be to apply to more programs.
And don't forget, you don't have to, even though you may start off as couples matching, you never have to fully commit to couples matching too. So that will be my only other thing. But yeah, I agree with Dr. Duke. It's no different than allopathic resident or allopathic candidate couples matching either. I don't think any other considerations.
Thank you, Dr. Duke, and thank you, Dr. Winters. We have another question that's about how can we best stand out on our sub-Is and how to prepare for them. Are there any specific resources that we can look up before we start a new sub-internship?
I don't ever want to promote books, but one book that I think is super helpful, or one thing that I thought was super helpful, is always the Philadelphia Guide to Inpatient Pediatrics. The reason why I always bring that up, especially if you're doing like an inpatient service, it used to always trip up so many people, and I used to always be like, oh, I wish you would look at this book when it comes to things like, acid base and electrolytes and those different type of things. Making sure that I don't care how much you know or don't know. What I always care about is intellectual curiosity. Are you trying to find out the reason why? Um, and I agree, like it's one of those things where you're just like, you really want to, well, I say I agree. I was just saw that Dr. Dale had brought up a piece of advice as well. But what I was going to say is that when you're doing these sub-Is, if you really just put your best foot forward and being able to show like, oh, I'm thinking about the next step forward, coming with like evidence-based things, actually just like pulling articles, and it's not even that difficult. Like you talk about something, literally just pull an article. You should be fine. Dr. Duke, I'm sorry.
Yeah, I would say that, I'm an outpatient pediatrician, and so we don't get the fourth year medical students really, but I'm thinking back to when I was in the hospital and working. Nothing impresses me like following up and following through. So if we were talking about urinary tract infections and something came up about, when to get a renal ultrasound or a VCUG or something like that, and you didn't know the answer on rounds. And then, I didn't even tell you to go look it up, but then you did, and you came back and told me, this is why we get a VCUG in this age group. And this is what potentially could happen otherwise. And you just take that step without being asked. That is a way to show that intellectual curiosity. It shows us that you are going to have the foundational skills that I still use every day, that I'm still looking up like, oh, we're only doing 3 days of azithromycin for atypical pneumonia now. I mean, I'm still learning and looking things up and going back to those resources. And so I'm impressed when I see a student doing that as well.
Thank you. Our next question is going to be, do you have any advice for what to look for in a program with candidates that have families and children?
Oh, that's a great question. I think that you can't go wrong with, is it a good place to have your children? Like is there is it a community that you want to raise your children in? And whatever that means to you as an individual candidate, is it more rural? Is it more urban? Is it have a little bit of both? And so I think that really looking at the landscape of and your values as a family, because yeah, let's be honest, I think that all of us are we know family comes first in terms of life. So I think that you have to think about what is going to suit your family and then retrofit a program that fits those needs.
And I always think it's important to remember that ACGME is ACGME wherever you go. So there are certain things, certain requirements that you must meet. But I also know too that with ACGME requirements, having that ability to be in a program that's understanding to those needs and being able to work with you through that process, I think is hugely important. You can talk to, and one of the things that we encourage, especially for candidates who have families who are thinking about it, is to actually talk to our residents who also have families as well. And we're more than happy to connect them with those individuals so they can just kind of get an understanding of what that looks like, and what it means for them, the challenges that may come along with it, because I think you'll find that across every program that you go to, there will be challenges and things that will come up for anybody who's considering having a family or already has a family in a program. And I mean, that's just residency itself.
And I'm just thinking about a couple of the recent residents who went through and had babies or had major family emergencies or incidents that that come up in life. And I think that it would be interesting to know how residency programs approach extending a residency. And if you are somebody who is thinking about starting your family in residency, like never take that option off the table, because it's not the end of the world by any means if you need to do 3 extra months of residency, or not extra months, but just beyond the 3 years because you couldn't get it all of your requirements completed within the time. And if as long as the program will be supportive to that sort of accommodation, that would be a very helpful thing to know, because you just never know what's going to happen if you are starting your family, or you know, family things and needs come up.
Yes, thank you. There's another very interesting question, which I think is very universal. How do we deal with the imposter syndrome that comes from being a medical student who's gonna just apply for, residency this year or in the coming years? How do we get past that feeling?
I was going to say, when you find out, let me know.
I was going to say, let's all figure it out together.
Oh my God. I think imposter syndrome was like my it never fails. I was just having this conversation with my intern. So we're starting intern orientation, and the question I always ask everybody is, tell me what's the thing that you're super excited about? What's the thing that you're kind of nervous about? And university, everybody is, very nervous about certain things that are associated with imposter syndrome. The most important thing to remember about imposter syndrome is one, understanding, like, even now, should we even call it imposter syndrome? Are we giving it too much power in that regards? But really just being completely open and honest and having a conversation of what is our biggest fear, what is our biggest concerns, and really being able to just sometimes take a step back and say, what happens in the worst case scenario, right? I always think about that from the lens of, biggest thing that I thought about that for was failing my PED sports. Because it was just like, oh my God, what happens if I fail my PED sports? And I finally had to say, well, if you fail your PED sports, guess what happened? You just take them over again. And that's the second it happens. No one asked any questions or anything like that. Thank God I passed my PED sports my first time. But at the same time, it was those type of things where it was just like, oh, in the back of my mind, I'm just so thinking about it and worried about it. So I think that's how I usually approach imposter syndrome. It's like, what's the worst case scenario? So you are told, like, oh, this was incorrect. As the type A personality, I can tell you it hurts our feelings, because we're always usually the smartest kid in the class. We were always the one who the teacher said we knew everything, blah, blah, blah. And it's like, oh my God, I'm not perfect. Oh, what am I going to do? Just getting over that fear, I think.
Yeah, and being in when you go to medical school and you're like, oh, I'm in the middle. that was hard truth for a lot of us, I think. But I also think just thinking about what are the expectations of you as a resident and as a doctor, that can also be like, it can help ground you. So if you guys think about what you expect from your own doctor, right? You expect them to be competent and smart. You're in medical school and you're about to be pediatricians in 3 years. And so you're that, check. And you expect them to care about you. And so I think that if you can look inside yourself and say, yeah, I really do care about people. I really care about what happens to this patient. That's like a huge aspect of what's expected from you, from your patient. And then also from your program, but really what matters more is what's expected from you, from your patients.
Okay. Thank you, Dr. Winters, Dr. Duke. One more question. What is your advice about utilizing the geographic and program signals on ERAS? And a follow-up question for that is, if we do not have a home program and we'll be doing away rotations for most of 4th year, how can we explore programs and do our best for each rotation and strategize those signals?
So I think that so the question was about geographic signaling and what else, Faria?
Geographic and program signals primarily, and then how can programs utilize signals if they don't have a home program?
I don't have a home program.
A home PEDS program, yes.
I would say that we do use geographic signaling, particularly because of just the land. I'm in Texas, and I don't know if any of you watch the news, but it's been a little rough with different changes and things that are going on. And so we do use geographic signaling, and to kind of get a sense of if people want to come here, have establish relationships here, or have a reason to come to Texas. And so that is a signal that we pay attention to. And yeah, I'll let Dr. Winters kind of speak to the rest of it.
Yeah, I think the biggest thing is, remember, for geographical preferencing or for signals, it's primarily well, it should be only used to be able to help us to determine who we want to invite for interview, and then that's it. It should not be used to help to determine who we want to rank or any of those type of things at all. And just to Dr. Duke's point, is really to be able to help programs to be able to understand who. It's usually used for individuals, like, say, for instance, if you are from California, all of your training was in California, and then you applied to our program in Jersey, and like, well, why did this person want to come to Jersey? And being able to have that understanding, like, oh, they preference me, or they did a geo preferencing, or they did a signaling, lets me know, like, okay, they just wasn't pressing buttons and just going click, 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 all of the different programs, because people do that at times. The problem with geographical preferencing is the geographical locations can widely vary. So sometimes it can vary to the point where individuals may say, like, hey, I'm really interested in the Mid-Atlantic area, but they really meant the DMC, the DC, Maryland area, not necessarily the Jersey area, right? So then it can get a little hairy that way. The biggest thing that I will say is, it's really meant to be a way for you to let programs know, hey, I'm seriously interested in being considered for an interview. Also, rest assured, I can't see other preferences, right? So you have multiple options to be able to geo-preference. You don't only have to pick one geographical area. A lot of people get worried about it because they're like, oh, I don't want to pick this, and then somebody else the program can see I have this. I won't see it, so I won't know. Don't worry about those things. However, if you really don't have a preference at all, and you're just like, I don't even have one, I don't need to pick one, to pick not one. In terms of the signaling, though, I would definitely say this is a huge consideration. And we talked a lot about this during some of the task force meetings around this with ERAS itself, which was thinking about it, and ECG, the AAMC, thinking about it in the lens of, for osteopathic programs who don't have a home program, to be able to signal. So the advice is usually, if you have a home program, don't signal that, because we already know that that's going to be a signal for you. But for programs like osteopathic programs who don't have that, then it's like you kind of you're losing a signal, right? You lost this kind of one disadvantage. Unfortunately, there's not a real great answer to say how to be able to make up that one signal. But what I will say is that I would definitely be intentional about who I put my signals for. So if you really are interested in a program that is one of your, like, high reach programs that, it's a long shot, but I'm going to try for it anyway, of course, by all means, signal. However, if it's a place where you're just like, I'm kind of necessarily interested in, but not necessarily, I would really preserve those signals and not just give them all to my high reaching. I wouldn't give them all to places where I'm just kind of like, I know I'm a shoe-in for it. I would really be intentional in thinking about where I put those signals. You only get 5. So think about it in the lens of, like, that rose and bachelor. Who would I give, or bachelorette? Who would I give these 5 roses to? And I think that that's the most important thing to kind of consider. when thinking about it. It's not the end all be all. However, it does help, especially for some of those programs that you may feel is maybe a little bit of a reach.
Thank you so much, Dr. Winters and Dr. Duke, for the incredibly thoughtful discussions and the gems of advice you shared with us tonight. We'll officially be wrapping up for the evening. I'd like to also say thank you to Dr. Dell for joining us today and the incredible insight he provided throughout the chat. We hope everyone was able to glean some incredible advice from tonight's webinar session, and big thank you to our panelists for today. As application season approaches, we want to remind you again that we'll be continuing with our regional webinar series with our mentoring sessions for the rest of the month, and then moving on to a residency program series throughout July and August. Be sure to scan the QR code, and we'll officially head off to close out for this evening. Before we Dr. Winters, go ahead.
Oh, I also want to say thank you so much for letting me come aboard. Have
Thank
a
you so much,
fun
Dr.
night.
Winters.
Take care. Bye.
Thank you. Okay, before we transition officially into our resident happy hour, be sure to scan the QR code, give us to fill out our post-webinar survey. Make sure you follow us on Instagram, Twitter, and join us on our listserv for email updates throughout the year as we proceed with updates for the rest of this cycle. Okay, I believe our residents may be here.